Listen to your lungs. Did Sue tell you I took it on Saturday night at dinner? Because we went to Osaka, which is the big smoke grill. She looks at me, because I was sitting way back from the grill, and then I took that out. She goes, I suppose this affects your breathing, doesn't it? I'm like, just a little bit. Just that smoke flaring up on the grill.
Where is everyone?
They all ran to the center of the hallway, if that helps you.
Jeff? Jerry, how are you?
Where's our
Good.
public? You
How are
apparently
Good.
didn't put anything controversial on the agenda.
Minnesota Lutzen.
Oh, yes. I ended up grabbing the warmest sweatshirt I had.
Well, this weather means we could be ice fishing on Thanksgiving. I know people who have already been out.
Really? It's thick enough.
If you look in the right places.
Yeah, driving down to the cities over the weekend and see that skim of ice on everything. It's amazing how fast it becomes a thick layer.
Well, all that rain brought the temperatures down. It means that they were closer to ready to, closer to ready to freeze.
Yeah.
Judy's gone too. Everybody's gone.
Madam Chair, for waiting patiently for us.
One more of you's missing.
She'll be right back. Yeah.
There we go. At least I didn't have to bark.
I think I forgot a pen.
All right, those of you tuned in, I apologize for the little bit of delay here, but we will start the Cook County Public Health and Human Services meeting, November 20th at 8:32 a.m. And we will start with the consent agenda. Does anyone want to pull anything? Can I get a motion to approve?
So move.
A second?
Any discussion? All in favor?
Aye.
Any opposed? All right. We didn't tell Greg we were starting. Valerie, do you want to do a quick update before Greg gets here?
Allison?
Valerie?
Or Valerie, sorry. Valerie? Allison?
Yeah.
She looked at me and she was just going to go.
Sure, I can get started on some of my updates. So Grace Griniger, our new public health coordinator, has started. She began in earlier this month with distance orientation. We've been doing some video meetings and telephone meetings with her and I, and her and Joni have been connecting as well. She and Joni both went to the annual LPHA meeting last week. So even though she's at a distance, we're taking advantage of any chance we have to make those connections. And she will be starting here on site full-time at the end of December. Some updates from the agency as a whole. It looks like Craig's just getting here, but I'll give a few updates as he gets settled in. We are working with the Public Health and Human Services Advisory Committee to discuss the formation of a local mental health advisory council. This is a statutory requirement of public health and human services boards to have an advisory council that has a certain representation of consumers of mental health services or families who have received who are parents of children who have received mental health services. Previously, we were folding that into our Public Health and Human Services Advisory Committee as a whole, but as we really dug deeper and learned more about the requirements, and with consultation with our co-chairs, determined that it would really be valuable to form a separate standalone advisory committee or task force. So as we learn more, as we have more information to share about recruiting for that committee, we'll of course be bringing timely updates to this board.
Thank you. Are you ready, Greg?
Yes.
Awesome. No pressure at all. I already called her the wrong name this morning, so.
My name's Greg.
I might call you Paul, you never know.
This is just some data I thought would be interesting for you to see.
Thank Thanks, Greg.
I have 13 copies of everything.
Really?
You know all this by heart. So this is just, I don't know, people in my job like to collect data, income changes. Outpatient right now, during the year we serve 28 people. That includes the people who are in group. So you can see it's pretty similar, I would say, to last year. A few more people in group. Then, generally, I would always say we serve about 20 people, and that was usually true, but we are seeing more people coming into outpatient. Part of it is people who are voluntary. They just want some help. I see a rise in that. Rule 25 assessments. I think we're on track to be pretty similar to the last 3 years, in the high 50s. You see that if you look down to 2014, 13, there were quite a few more people, but since Grant Porter started doing assessments, we just see fewer of those people. The man who was doing the assessments, Rob Primo, has become the Director of Social Services. He's going to do both jobs. I talked to him last week, and I think the reality of that is setting in, and so I think we'll be doing more assessments for them until they replace Rob in that co-lieutenancy position. But I'm just guessing at that. I always think it's interesting to see how people come to the group or come to outpatient compared to the state, especially. So that's the next thing on the list, outpatient admissions in 2018. And the only data I could compare to is 2017. Every year they take the DANES, which is a kind of a demographic form that I fill out for everybody who's in treatment. They collect that data and they send you many pages breaking down all the data they receive to us into many demographic categories. But we're pretty similar to the state. A lot of our clients come from court probation, similar to the state. It's like fewer self-referred people, a higher number of people who come to see us because there is some child protection issue going on. And drug court. They don't actually have a category for drug court in the DANES report. They call it specialty court. That could be drug court, could be DUI court, could be mental health court. So there isn't really much of a comparison there, except that 2% of our people this year were actually referred to us by our drug court. And I'll talk about the drug court a little bit later. So the percentages, I don't think they're that much different. They're significantly different. Plus, we're looking at such a small population of people compared to the data collected on people statewide. So I'm not sure comparisons are very realistic anyway. But interesting because you see by the admissions by, God, I'm nervous.
Now we know.
We didn't before. You know all of us.
I know all of you, but
Do you want to sit up here with us instead of here?
no.
It's more pressure on this side. You can sit here and.
For some reason, I thought I had to be here at 9 o'clock.
It's all right.
Oh.
So anyway.
We entertain ourselves.
Okay.
You're doing well so far.
Yes. So far, he said, so far.
So everybody who comes to treatment, they have what's called a primary diagnosis. So it's the substance that is causing them the biggest problem. So that's their primary diagnosis. And then under the primary diagnosis are what we call secondary and tertiary diagnoses. And those are other substances that are having problems with. They might be having just as big a problem with a secondary substance. For instance, the primary is alcohol, secondary is meth. They meet just as many criteria for a substance abuse problem for meth as they do alcohol, but they got in trouble for alcohol, so that's their primary substance. And that's the kind of data the state collects. And so what I did was I took, in our groups, the primary diagnosis, and then in parentheses, I added another figure that just relates to the secondary diagnosis. So you can see we're higher than the state. Most of our people are still having trouble with alcohol. The next category is methamphetamine, similar to the state. Then opioids, 14% compared to 11%. I don't think it's significant difference. And then I added 2 just for our own information. How many of people this year, primary substance is heroin, not just opiates, but they've been using heroin. And how many of those people have been shooting up, either the heroin or meth? So we're pretty similar, except in my experience, in the last 2 to 3 years, I'm seeing more people who identify heroin as the substance they are having trouble with, not pain pills, but heroin, and more people are shooting up. 5 years ago, a client would have been loath to say they were using needles. They just, if they were, they wouldn't admit it. We might find out later in treatment as they become more honest and comfortable. They say, well, yeah, I shot up a few times. Now, they just, at least the people who admit it are very open about it, and they're shooting up heroin, but also shooting up meth. Shooting meth is becoming pretty common. You know, not statistically, it's not like the greatest number, but I'm seeing it, and people, what strikes me is that people are so candid about it. Oh yeah, I've been shooting up meth. So whatever stigma some people have seems to be removed now.
Or the opposite,
What do you mean?
meaning it's even more attractive.
Yeah, well, I've never shot up, but it's a quick route to a very big high.
But even in people's minds, it might look more attractive.
Oh, sure. Well, yeah, there's a credibility associated with it. Yeah.
I'm serious, yeah.
Yeah, but I'm
Wow.
that's interesting to me. So if you look at a map of Minnesota, broken into counties, and they're talking about the opioid crisis, often what you'll see is Cook County doesn't seem to be affected as much as the rest of the state. St. Louis County is dark, and that goes all the way up to the top of the state. And then there's Cook County right here, and we're a lighter color. And I went to a conference the end of October, so it's a lot of my peers, and there for 3 days, and we have lunch and we talk. And we were talking to several people I know and several programs there that are pretty big. And the talk is, yeah, there's an opioid crisis, but are you seeing all the meth we're seeing? That's what my colleagues are talking to each other about, is the meth, the rise in meth use. And we're certainly seeing it here. It's cheaper, it's available. Harry Swift, the guy who really established this program and established, I think he deserves all the credit for what he did to bring recovery to this county. He would say that our problem is addiction. It's not meth. When I started working with him, meth then was big too, and everybody was, and the whole state was concerned about the meth problem, and Harry would say, we have an addiction problem. Meth is just what's available. And I've seen that over the years, that when meth dried up It dried up when they started regulating ephedrine in the drugstores, and it became harder to cook. The meth problem decreased because the availability decreased. Now the meth is coming from Mexico and South America. It's more available and people are using it again. As an addict, I can tell you what I was addicted to was changing how I feel. That was it. And I found daily the substance that would do that for me. I wasn't an alcohol guy, I was a pot guy. I never abused opioids, but I did get them under prescription, and I would get 20 at a time, and the first 5 or 6 were for the pain. You know, I was so grateful for that, but I always used all 20 because it just made me feel so good. I'm in recovery from addiction, specifically alcohol, but I know in my head that I love the way opioids make me feel. And I would say that's kind of a risk for me. So I go to the doctor now, I go to the dentist, and they know I can't have any narcotic pain relief. And what I've learned is you can do without it, but I wouldn't have believed it then. For pain, tooth pain, I mean. I don't know what it's like to have a serious illness. But I can never forget how accomplished and on top of the world that drug made me feel. That's how it makes an addict feel. I have people in my family who are not addicted, and they take their pain pills if they have to, only as long as they have to, because they don't like the way it makes them feel, which is just start. You know, I don't understand that, and they don't understand the euphoria I got from it. So there is definitely an opioid problem, and it's either we're not seeing it here, people aren't talking about it, maybe our numbers are just so low, it's never going to create a big explosion of concern. But I do know people who have overdosed, they've gone to the hospital, they were overdosed, never got a referral for those people. I don't know what happened to them, but I hear about this in the grapevine, maybe pretty much the grapevine. So I think we need to be prepared for it. You know, and our numbers are always low for everything. When we, 28 people in an outpatient program, that's a small program. But those are 28 lives and people we know. And the impact of them getting sober and changing their lives has rippled through the small community, I believe, just the same way their use rippled through this community. So I think the results are significant. And so if our opioid problem turns into a crisis, but just a handful of people, those are, I was going to say those are God's children. I'm not religious, but they're people that we live with, and we'll have to deal with them. I've gone to twice now to training for naloxone. And every year I take up a bunch of these kits. There are needles, little doses here. I've got about a dozen doses in my office. This is available to anybody. This is available to you. I got my training from an organization called the Steve Rumbler Hope Network. Steve Rumbler was a person who died of an opioid overdose. He was, by all accounts, just an accomplished person who hurt himself, got hooked on pain pills, prescription ran out, he went to the street, and in time he died of an overdose. And the family was a well-to-do family, and they were just, grief-stricken by their loss, and they decided they had to do something. And what they have is created this organization that will come up here and talk to us, talk to you. They have a stirring presentation. At the end, they'll take out the oranges, they'll take out these kits, they'll show you how to load up the syringe, you'll practice stabbing an orange, and then you'll walk away with one of these kits. And what they told me, what we know, that it will not hurt anybody. It won't hurt you. If I give you this today, it's not going to hurt you. But when you if you happen across somebody who's overdosing, you learn what those signs are. That person's going to die anyway, and so you have a chance to save their lives. And you don't have to worry about giving the shot the way you give a shot at the doctor's office. You load up the syringe, you stab them in a large muscle. You don't have to worry about airing the syringe because the stuff is just going to go into the muscle. They won't feel a thing. You wait 2 minutes, and if they haven't come out of the overdose, you give them another one. You just keep doing that until 911 arrives. So we've been talking about bringing, we haven't actually talked about it. I brought it up that this organization would send somebody up here and train in the street. I've never had to use it.
So Greg, is the use of that only for an opioid overdose?
Yeah.
And there are specific things that you would be aware of before you would administer that?
Yeah. You learn the signs of the opioid overdose.
So you wouldn't have to know that that's what's going on? You would see the signs and?
You would know, because you
Okay.
would know the signs.
And that's part of the training.
And that's part of the training.
Okay.
But if you're wrong, you aren't going to hurt the person.
Got it.
And then 911 shows up. You'll flip over. Our outcomes, patient outcomes. So the only statistic from the state is how many people in an outpatient program, what percentage of people successfully complete, about 40%. This year, we're about 51%, so it's, I don't think it's statistically meaningful. I put 70% in parentheses just to reflect the people who are in group right now. If there were 9 people in group right now, you can never predict who's going to do well, but at least 5 of those people are about ready to complete treatment. In a way, it's kind of a meaningless statistic. 1 year sobriety while you've been in outpatient treatment isn't what we're looking for. Statistically, for alcohol, most people with one, I don't know that I do see this here. This is the statistic, nationwide. A person who has 1 year of sobriety from alcohol is likely to have gone through treatment 4 or 5 times over the course of 3 to 5 years. So that's what they're seeing nationwide. So that first year is important. I tried collecting data from people after they left outpatient, sending out yearly surveys, didn't get many returned. Didn't even get them returned from the people I was going to AA with that I knew had been through. And when they would say, well, I'm sober. So it's hard to collect that kind of data here, but I think we see about the same number of people staying sober for a long period of time. In outpatient, we use some evidence-based programming. So that means that somebody has created a program, very specific steps, how to administer this program in your outpatient group. They researched the success of it over, hopefully, a period of 3 to 5 years. And if you want to achieve the same results, you must follow the prescribed way of treating people with this program. We've always used something called 12-step facilitation. And that's one of the ones we use. That is to give people experience doing the 12 steps. They learn all the usual stuff about triggers and cravings. But the important part of that program is they get into AA up here. We used to have an NA program also. Because what my experience, the experience of a lot of people in my field, is the thing that really seems to predict success in sobriety is identifying with a group of people who are also going through recovery who can support you. What's interesting is that this, data about AA is really hard to collect, and even harder than it is to collect about success out of treatment programs. But, I'll go on record as saying AA has as great a success rate as any evidence-based treatment program. It just does. And so that's our first line of attack, I guess you could say, is let's just do the thing that works. But there's a lot of resistance among some people. This is recovery from any kind of addiction requires a lot of fundamental changes to your lifestyle and your way of thinking. And that is because we're all human beings. Throughout evolution, we've developed into a being that creates habits, so we don't have to every day rethink what we should do in a certain situation. So we're creatures of habit, and an addict is a creature of habit, and we're trying to teach them new habits. And there's just a human resistance to that. It's really uncomfortable. I went to treatment. I came back. I thought I was cured. I thought I knew everything. So this is all about intelligence. I knew I'm never going to go back to that again. And within 4 or 5 months, I had relapsed and was using again. Then I got sober. And that day I just decided I'm just going to do AA. I'm not going to try to think this. I tried to think my way through it. So I was motivated to make those changes. I was so scared. I was willing to go to AA. I was willing to tell my fake sponsor that I wanted him to be my real sponsor. I was willing to really do the steps. And because I was motivated. So in order to help people in outpatient change their behavior, we approach this as a problem of motivation. And we have various ways to do that. One is the 12-step facilitation program. Another is something called the relapse prevention program. Now this is a real cognitive-based approach to recovery. It's not, in and of itself, I don't think it has really long-term results, but what the creators of this program, this came from Hazelman, say that in addition to self-help recovery groups and knowledge about your addiction, this helps a person understand where their cravings and where their cravings are coming from and what to do about them. And that gives them another tool to sustain their recovery. We all lose, addicts, all lose control. And when I first heard that, I wasn't sure I believed it. Well, I didn't believe it. I didn't think I lost control. I think I just made poor choices. And then after I got sober the second time, I acknowledged that I'd lost control, and I thought I'd lost control of my behavior. I think what people really lose control of is their cravings. That's the thing they lose control of. Cravings are an emotional state of mind. I'll give you an example. I'll give you an example, me today. I've had a lot of sobriety, right? I'm still aware of some triggers that I avoid. For me, I just think that one of the biggest triggers that would create a craving would be some emotional crisis. So finding out my daughter died suddenly, that would be an emotional crisis. That would create a feeling I'd want to escape from, and probably a feeling I'd never had before. If I'm not prepared for that, it is so easy for me to, for that craving to become emotional, and then I'm making an emotional decision, and I'm likely to use, unless I'm prepared. Does that make sense to you? To everybody, but go ahead.
I mean, we all have it on some level if you think about it with food.
Yeah.
I mean, I had a
Yeah.
friend who had a sugar addiction, and I just couldn't wrap my head around that because you have to eat to live, and there's sugar in everything, and so the amount of levels that they had to go through to avoid that, and it didn't take much to trigger that.
Yeah.
I mean, sugar when you're happy, sugar when you're sad, sugar when you're okay, it was just...
That was alcohol for me.
Right, I mean, that's how I
Yeah.
associate it.
So, in this relapse prevention program, what we do is we ask them, and we're always asking people to do things, not telling them to do it. So we ask them to fill out this, and I'm going to give this to you. This is the first thing they get. And what we're going to try to do is, now I'm not going to do this to you, but you could if you wanted to. We want them to try to identify their 3 highest risk factors. People coming into treatment, they'll say, oh, I know why I drink. I know what I want. And maybe they do, but maybe they don't. Whether they do or they don't, we want them to fill this out and give it back to me, and they identify themselves what their highest risk is. So there are a number of situations that they think, this program thinks, is going to cover most of the cues for craving. There are 8 of them. And it's a self-test. They just answer this themselves. Negative feelings. Possible negative feelings create a craving. And they just answer the question. And if they've checked a lot of them, they know that negative feelings might be a trigger for them. And you just ask them to think on their own, just kind of estimate. How big a trigger do you think it is? And the circle is anywhere from never to always. And they do that for each one of the situations. They go back and they look at what their answers are. This asks them to pick rank all of them, but I see this asking to pick the top 3. And now they've given us the best way we can get about that person. They've answered the questions themselves. And then there are units that go along with each one of these situations. And then they work through those units. And basically what they're doing is they're learning why one of these situations would be a trigger for them. And what they're learning is what they think when they're in the presence of this trigger. There's this story. There was a guy in treatment, and he had road rage incident, and he drank and got a DUI. And we asked him, what happened? And he said, I remember, and I've heard this a number of times. He said, well, you had done the same thing. I said, well, what did you do? He said, I was driving, everybody was speeding, I had to speed to stay, I think he must have been going to the Twin Cities on 35, where everybody drives 80. And said somebody cut me off. I gave him the finger. He gave me the finger. pulled over, he wanted to fight, you'd have done the same thing. And then I just went after him. Well, but his description of this event is that all the power for that craving was in that other car and that guy. And if that was true, then everybody that guy gave the finger to would have a road rage incident and would have drank. The power isn't in that guy. The power is in what you were thinking when that happened to you. That's where the power was. And so what we want them to do is, and this takes a lot of practice, this is hard to do, but go back to that situation, think about what happened, put your best guess of what you were thinking, and again, hopefully that they're reasonably accurate. And maybe their thinking was, my brother always did that to me, and that just ticked me off. And so, the power isn't in the guy giving you a finger, the power is in your thoughts and your thoughts. You're kind of, you're reacting to that guy the way you reacted to your brother. So what's going on with your brother? And so that's the approach you take. After this guy told me the story, I've told this, if you heard this before, it's okay, but it was after group one night, and I'm driving home, and I see somebody I recognize who was in group once, and he waves at me, so I wave at him, and then I look in the mirror, and as I'm driving by, he's giving me the finger.
Oh, no.
And my reaction was, I didn't get mad. I thought, I jumped to right, he must be kidding. He must mean it as a joke. So there's, sometimes I use that as an example. There are different ways to think about these things. And so, you want to, what we want them to do is examine those thoughts then that they have. Are they accurate? Or is there some, irrationality about what you're thinking in that moment? So that is the next step, is to examine those thoughts, see if they make sense. If they don't make sense, what could you think instead? What makes more sense? And then can you train yourself to do that every time you experience a craving? Can you look at what you were thinking and you examine it, see if it makes sense? If it doesn't make sense, there's something that makes more sense. And can you practice this? So this is a big change. Always examining your thoughts. It's hard. It's hard to remember to do it. And so we try to get them in group to practice examining your thoughts, so it doesn't become. So maybe it'll become second nature to pay attention to your thoughts. People in AA pay attention to their thoughts all the time. Another reason to go. Another thing we've added this year is something called MRT, Moral Reclination Therapy. What I will confess to you right now that I just whipped this up right before I felt like I had to hand something out about this therapy. This is another evidence-based program, which means that years were spent addressing the issue of criminal thinking. People were trying to come up with a program that would address it in alcohol and drug treatment. It's kind of like writing a movie script, I think, is you do the first draft and then people start making changes and you make the change and you see how if the changes help or hinder what you're trying to accomplish with that person. And then in 20 years, you end up with a program that you think is good, and then you start testing it. You have a lot of confidence. They have a lot of confidence in this work, and so now they bring people together in groups, and they use the therapy and follow it for a number of years to see what the outcome is. And they determined that this therapy has pretty good outcomes when treating people with criminal thinking. And what criminal thinking is just the rules don't apply to me. Make up my own rules as I go along, and I get in trouble. I mean, trouble, this is developed in the criminal justice system, so I get in prison, I go to jail a lot, I've got 8 DUIs. The world, I'm a victim, the world doesn't understand me, and I just have to survive. This is specific for people who've been identified as having criminal thinking. So where the 12-step facilitation program and the relapse prevention program is something everybody in outpatient gets, this is something that only people who have been identified as having criminal thinking get. And they don't, this person is most likely to go to a residential program, and our CD case managers, this is new, we just started this a few months ago, but there are residential programs that do MRT, and so we've matched 2 people in residential treatment with programs that do our MRT. They're doing the MRT program, and when they come back to outpatient, they will continue it. One of those people is back, that person is continuing it, and there are 2 other people who hopefully will come back and they'll continue doing it. I really debated whether to show you this or not.
Ooh, then we really want it.
Bring
Bring it on.
Oh, shoot, see?
Come on.
I want this back.
Uh-oh.
And I didn't even make a copy for myself. I had another 10 minutes. Good. So what they get is, they get a manual. All evidence-based programs give you a manual. And what they say is, do it exactly as we lay it out, because that's what was studied. If you start changing things, you start fudging them, you're no longer doing our program, and it may not work. This program is really specific. There's a manual that comes with it. It looks like this. It has an outline for you to follow, and then you do each step. The way they train, I'm not even experienced doing this. But they told us they're confident we can do it if we follow it, if we just follow the steps. And the way they trained us was we went through MRT therapy as clients. We did all 10 steps. We, every step, for instance, you'll see this one, they're talking about honesty here. So that's the first step, is address your honesty. They want them to make a life pyramid. Part of the instructions are don't use words, only drawings. Well, most of this program, people are using drawings, not words, because they want them to access the left side of the brain.
Wow.
If they use any words, they have to redo it and come back next week. The whole thing is about following the rules, whether you agree with them or not.
Really?
They then have every step, so every step has a little exercise. A lot of them are a drawing. And then they have a testimony to give in front of the group. In this first step, they have to memorize these 10 issues that they have to cover in their testimony. They stand up and present to the group. You have to memorize that. You can't have a sheet. You have to do each one in order. You have to do it exactly right. If you don't, come back next week. So you're dealing with people who don't follow rules, don't even think they apply to them, and now they're in this controlled situation, they have to stand where they're supposed to stand, they have to memorize something, they have to use drawings on words, and they have, et cetera, et cetera. And it takes people, apparently it takes people many weeks to get through the first step. At the end, they want people to realize that you live in society by following the rules, whether you agree with them or not, and that helps you access your moral center, where now you're behaving from some values and morality that includes other people rather than the thinking where I'm the only person that matters and I have to get my way. I'm sure next year, if I have more experience with this, I can talk about it more. It was hard going through this as a client, though. I mean, we were making all kinds of mistakes. This first pyramid, I put everything on I reversed things. It kind of was dyslexia. So instead of putting what I was supposed to put on the left side of the pyramid, I put it on the right, and do it over again. There was another exercise where we had to, in one of the other steps, we had to have make 6 statements about how I spend my, no, it was 10 ways I spend my time every day. So you're looking at, well, I brush my teeth every day, et cetera, et cetera, et cetera. I only had 9. I could only think of 9. And I'm, I'm a therapist, counselor, and this is just training. And so I went to the group, and I only had 9. And they made me do it over again. And so for my, how do I spend my time during the day? And I'm sure clients act like this. My 10th one was nursing my resentments. Now, a real client would be told, okay, come back next week. That's how I say it. I'm talking about maybe this over thing. So, I don't think I'm a criminal thinker, but, I'm really in touch with the thinking that at some point, I don't have to follow the rules. In that case, I don't have to follow the rules because it's just training and I'm a counselor and you're all my colleagues. Didn't work. So I'm really anxious to do this though, because the people right now who are dealing with MRT have been through many treatments, and they're the people that puzzled me the most. Just couldn't know how to get them to show up and do their assignments. So I'm hopeful that's going to help. I think the last thing I'll talk about is substance recovery court. So this year, we had 1, 2, 3, 4, 5, 6, 7 people in SURC, SURC, the Shore Substance Use Recovery Court. 2 of them are graduates. One of them has just begun, he's in outpatient. 1 person is in jail, and 3 people are in treatment somewhere else. This is the handbook that clients get. And we go through 5 phases, and each phase is 90 days. During the first 3 phases, they're probably going to be in treatment somewhere. So let me just describe these phases. The first one, during the first phase, the first 90 days, they come to court every other week. They all come as a group. The court is not closed, so there are other people in court watching, who are here for some other reason. So they do this in public. They're asked how they're doing. Have you stayed sober? Are you going to meetings? What's happening in treatment? The department, the thing that they have to do is they have to show up. And it's interesting how for some people just showing up was such a challenge. Just showing up. And they would say sometimes, I didn't know I had to show up. I forgot the time. I didn't know where to go. Which to us might be just startling. If I had to show up in court, I would know exactly when to show up, and I'd be early. But we've been through court many times. Careless about it. So just showing up is a big step. They have a curfew. They have a curfew, 9 o'clock. They also have to come themselves to their probation officer's office at specific times. They get UA every week. They also agree to let the probation officer make home visits whenever he wants and give UAs. Some of them are put on a schedule of UAs, which doesn't mean they know when they're going to get them, but they have to call every day a number, and the number will tell them a color. They know what their color is. If their color comes up that day, they have so many hours to show up at probation and get a UA. And then in the first phase, they're in treatment, and where they have to start addressing any problems they have with mental health or physical health. So start seeing a therapist, seeing doctors. And then some people, a number of them, just had nowhere to live. They could stay with relatives, but the relatives were using, so they're couch hopping. So they have a housing problem. And so if they're here, somebody here is helping them find housing. If they're in residential treatment, housing is going to be one of the issues to address as they transition back to the community. Second week, again, coming to court every other week, same curfew, 9 o'clock. Now we want them to start attending support group meetings. Hopefully within 90 days they've gotten housing, and they begin to work on a budget. You see how we're addressing basic needs and issues many people just don't address successfully on their own. Third week, again, every other week come to court. Now they have 10 p.m. curfew. Now they don't have to come to see their probation officer every other week, but the officer will have to call in for UAs, and the PO visits their home every month. But also now they have to begin working on a relapse prevention plan. So they've been through treatment. Hopefully they've done treatment program, and so a relapse prevention plan isn't something foreign to them. They've been thinking about it and getting some help addressing what places do you have to stay away? Who do you have to stay away from? What triggers you? What's your plan to deal with that? Do you know what triggers you? And then we also expect that CERT wants them to start doing something that they call pro-social activities. That's kind of a creative part of this program. A lot of them start hanging out with different people. A number of the ones I know started playing pool together. The fourth phase, now we come to court once a month. They have 11 p.m. curfew. They still have to see their probation officer. That's once every other week. Continue to go to AA or your support group. And then they start addressing larger needs that they may have already been addressed in treatment, like anger management. Some women who have little children, so they may have gone to a residential program that also feeds children, so they can learn some healthy parenting, by the fourth phase, we want people to either be employed now or really making progress towards employment. So you can see they give them a lot of time to accomplish these, what we probably consider really basic goals. Then the fifth phase, again, 90 days, monthly court, 11 p.m. curfew. By the time they get to the fifth phase, you'd think that they're pretty close to graduating. But we have had people who just tanked in the fourth phase and had to start over again. What's nice about this is that when people go to court now, they've got years of going to court where they're the bad guy, the criminal, and court was a terrible experience for them. Now court is becoming a supportive experience. The judge, the attorneys, the probation officers, everybody went to a week-long drug court training several years ago, and we have refresher drug court training every year. And it's really, I've seen such a change here with our judge, for instance, and our attorneys, that they use the appearance before court as a time to congratulate people for their success, if they have it. If they relapse, they, instead of being punished for that, they are supported, taking the next step, whatever it is. They do what they can not to instill shame in the person. You know, relapse for people who are really trying to recover can be a shameful experience. I mean, it just seems to be the place we go for early in recovery if we relapse. And so hopefully in treatment, what they're learning that this is an illness. In my group, sometimes get a lot of pushback about calling this a disease or an illness. You know, it's all the notions we have about illness. This can't be an illness because I pick up the drink or I pick up the, but they get this is the educational part. They learn why it's called an illness, and that if they can't bring themselves to call it an illness in treatment, then we just ask them to call it it. But accept that it has these characteristics. You don't care if you call it an illness, but call it it. So accept that it's changed your brain. It created, the changes are made in the part of the brain that doesn't think. Sometimes call it the lizard brain. Addiction is a disease of the brain that manifests itself in a change in behavior. And the behavior that's changed is the decision-making, goal-setting process. That gets changed. We get rewarded for using. And then we use when we experience cravings. And cravings are the things we've lost control over until we can identify what triggers the craving. So this is a process. And along that process, it's a lot of work, you know, a lot of introspection, and it takes time, and you know, it's a relapsing illness, and it's going to happen. Doesn't mean you're a bad person. Doesn't mean you didn't want to get sober. What it means is there is a cue out there for a craving that you just haven't learned how to deal with right now. So relapse is a real opportunity. You're face to face with whatever it is that would cue you to drink or use when you really wanted to get sober. This is a big issue. That's the chance to address it. So in the past, people would relapse and they'd come to court and they'd get thrown in jail again. Now, in this court anyway, the focus is on how we can address this relapse in a way that will help you. And the people do feel a lot of support, even the ones who weren't able to stay sober and had to go sometimes to jail, but went away to treatment. So I'm just, I'll tell you you, I had an audit. For a person in my position, an audit is the scariest thing you can imagine. I mean, even if you think you're doing a good job, the state comes in and they can look at anything, and they do. And so you got 2 years of clients, 2 years of files, and you hope every one of those, you document things right, you're doing things right. It was a good experience for me. And I've just forgotten why I brought it up. I'm thinking back to the audit. Sorry. I don't know why I brought it up. Nothing to do with it. I was hoping I'd come to it. I'm sorry. The discussion we had during the audit was about how people, treatment plans, and how people are treated in treatment, and how that is changing. And one of the people that clients we audited was actually 2 of them were in drug court. And both of them went away to treatment after just not being able to get through the phases. And my question, I guess, for the auditor was, what can we do when these people come back? What do other people and other programs do when people come back? Both of these people, when they left, it's common that people will say, I can't get sober here. I hear that a lot. I can't get sober here. And so the question always is, can that person come back here? You know, is it really true they can't get sober here? In AA, called that the geographic solution, that I'll be okay if I move somewhere else. So the reality is that the problem really isn't here. It's here. What can you do to deal with whatever it is you think makes this place unlivable for you? And one of the gaps we have up here is housing. Well, you know that, housing gap. But even for a person with a good job and good credit history, just finding a place to live can be challenging. If you are in this little community a known criminal, a known drug user with no work history, housing might not even be your biggest problem. And so we're talking about how to support these people when they come back, and what can we do in the outpatient program to support those people. And we're not sure we can right now. If a person really, their only way of sleeping at night is staying with friends that they've used with in the past, they're always going to be exposed to using. And if they move back to a family that is using, that's a problem for them. And the question is it a problem for us? Is that a problem we have to focus on solving? And then drug court, they have decided that this is a problem that somehow has to be solved. We don't know how it will be solved. I think that's where I was going with the story. Wasn't a bad recovery, was it? Any questions?
Anyone have questions? Go ahead.
Yes, thank you for that presentation, and I feel that you have a wonderful
background so you can help people, and sometimes, and most of the time, that is half of the situation with the folks, that they know that you've been there too. But could you refresh me on what the Rule 25 is?
Sure. So in Minnesota, the Rule 25 is our assessment. It's how we diagnose chemical dependency. It's 18 pages long. It is divided into 6 sections. The first is intoxication or withdrawal. So when somebody comes to us for an assessment, the first thing we want to determine is, are they high or are they, excuse me, going through withdrawal? And people do come high, and there have been people, many, who have been in withdrawal. And so with the person who's high, you determine whether or not the interview is even going to be valid. If they're really drunk, send them to the hospital, bring them to the hospital. If they're going, and there have been 2 people who've been going through opioid withdrawal in the 7 years or so. And then we just went right to the hospital. Most people come, go sober, maybe they have a little hangover, but they don't admit it. And so we get through that first dimension. The second one is just their physical health. Have they been seeing it? Do you have a condition that you know about? When was your, asking when the last appointment was at the doctor? Are you taking any prescribed medication? So then that's a screen for their physical health. Are they getting the help they need? Are services available? The third one is their emotional cognitive health. Again, it's a screen. You ask them questions about depression, anxiety, trouble sleeping, any kind of trauma. We want to screen them to see if it looks like they have a mental health issue that needs attention, or that they have a diagnosis and they're getting attention. So we screen that. The next 3 sections are all about their drug use. The fourth one is their readiness to change. Do they think they have a problem? And yes or no? What have you done about it in the past? What do you think you would like to do about it now? And so we score their readiness for change. Is it really low? They don't think they have, or they know they have a problem and they're ready to get help. So you might score them a 0 or a 1 there. Other people come in with obvious, significant consequences, but they don't think they have a problem. They think everybody's making something out of nothing. They would score high. But they score high, meaning they have a low motivation to change. The fifth one is relapse potential. There we're just looking really, when's the last time you used? How often do you use? How much do you use? Have you ever been in treatment? Have you ever had any help with this issue before? And do I, as an assessor, what's my gut feeling about what they're going to do when we leave my office? Are they likely to use again? And the 6th dimension is recovery environment. This is the issue we talked about, housing and employment. Do they have a place to live? Is that place safe? Do they have a job? Or how are they getting by? How do you spend your day? What's a typical way of spending your day? Do you have people? Do you have children? Where are the children? Who do you live with? Do you have anybody who supports you? Or anybody who, if you want to get sober, or who support you? Or is your interpersonal environment just detrimental to you addressing this problem? And then, based on the scores in those 6 dimensions, you can diagnose their illness. What's happening with substance use reform in Minnesota is in the next 2 years, we're going to get rid of the Rule 25. When, and it's going to be replaced with something called the comprehensive assessment. When people go to treatment, residential or outpatient, the first thing we do is this comprehensive assessment. Because everything you do afterwards comes from what you discovered in the comprehensive assessment. Right now in Minnesota, if, let's say I live up here, I want to go to treatment, I don't have a job. I get up the nerve and I go to CEDP, and I say I've got to quit. CEDP says, we have a bed open for you. But you're from Cook County, they're going to be your responsible county. So you have to go back to Grand Marais and get an assessment, then bring that back to us. And this has happened to me, not to me personally, but just over the years, a few clients who finally got the, whatever it is, they reached a point where they just want to help. They went to the only treatment program they know of, residential, CEDP, and they had to come back here and get this assessment and then go back there. And neither one of them did that. It's just, you know, I can tell you from my experience, I thought about getting help, but the day I wanted help was the day I got fired. That's when I wanted help, you know. And I was lucky. I came here, and Harry, I'd seen Harry a few times before, and he did the assessment. He got the treatment. I was lucky, you know. But if I'd gone to another place, CDT, they'd sent me back here for assessment. Now, with reform, is a person who wants to get help can go anywhere in Minnesota, any treatment program, get this comprehensive assessment. They get scored to get diagnosed. They say, yep, you don't have any income. You do have a chemical dependency. There is a bed opening here for you. We'll put you in today. We'll call the county of responsibility, and then the county will determine the financial part that you are going to play with it. So it's a big change in just making access easy. It's less work, less paperwork for me. I mean, I've had people who came for an evaluation, they wanted to do outpatient, and so we had to do the Rule 25 and wait. Didn't really have to wait. We put it in the treatment, but then I do the comprehensive assessment on top of that. And it's just a shorter form that asks the same questions. So it's a nice streamlined way to do it. So you do the comprehensive assessment, and then you do a comprehensive assessment summary, which is those 6 areas I described in the Rule 25, give them a score. Then you do, for each of those dimensions, then you do a treatment plan that uses the information on the summary. Summary uses the information on the comprehensive assessment. You do a treatment plan, and then every week you do a review of the treatment plan. So you can see that everything starts with the comprehensive assessment. It dictates what you do at the end, really. And with the reform, that comprehensive assessment now is going to follow this person throughout all their treatments, no matter where they go, no matter how long they go. So there's going to be a continuity that we haven't had before. Right now, if somebody's in residential treatment and they go to some halfway house, I may not even know it. And they may want to know, they may want some information from me, I don't know. With the reform, we're all going to be involved with this client from beginning to end in some way. It makes, they have a real team who's been with them from the start.
Great, thank you.
Jerry?
Thank you, Madam Chair. Greg, I really appreciate your style in giving us this report and your honesty. It is so down to earth, and I'm sure it says how helpful you are to the people you're working with. Quick question in light of time, but how's detox working? Do we have a good detox availability, and can people use it?
We don't. Part of the reform is detox reform, and people are, I mean, it's being reformed in Duluth, but people still have to do it. You just don't have it here. I don't know that, I don't know, maybe you will, but I don't.
So if somebody needs detox, what happens? They go to the hospital and that's it? Uh-huh.
They get transported to Duluth.
Then that's where it starts. And if they then, at the hospital, they may start, I've known some people who have been at the hospital for days, they've done detox there. I've known people who will go to the emergency room and then they'll get a ride to detox and do it. But like everything, distance matters.
Yeah.
You know, so many of these problems have a financial cost that is just insurmountable. Especially, not just up here, everywhere else, but something I've seen just in the last couple of years is there are a lot more treatment programs opening up. And the programs that I'm familiar with that we've used are expanded. Like New Beginnings down in Waverly, they have their own construction team. Then they remodel their buildings. What they're doing is they're taking, as this guy described to me, they're taking buildings that were used for administrative or something else and they're turning them into residential places for people to stay, and they have their own construction people doing that. And then there are a lot of new programs opening up. The recruitment for counselors is vigorous. So I get letters just out of, these are bulk mailings to everybody. Would you like to change? So we're really looking for counselors, trying to recruit people we need, exactly need to expand the program. And so part of, something has to be addressed in Minnesota is workforce. The workforce has to be expanded. These changes are great. I feel like finally have not just legislatively, but professionals organized to make the kind of changes to treatment in Minnesota that we all want to address. It's a wonderful time to be in this business. Did I answer your question?
Thank you.
Any other questions? Jan?
I also wanted to say thank you, Greg and Jerry. You said it beautifully. Fabulous presentation. I have a million questions, but as I think of our community, and you've addressed many of these, there's a lot of holes in our community in terms of creating a community that really can support people and all of us with behavioral issues. I mean, clearly, this seems like a cultural problem, not just a few people have this problem. It's kind of, we kind of breed this, and ways that we can all work together and support each other in creating really positive change. Although so many of these programs are so military and rigid, which is also very interesting, that's the answer to a lot of these things, to a very complex problem, to simplify it. But anyway, it's...
I probably described it that way, that the outline says do this, do this, do this. But the important element they can't put on paper and make you do is the interpersonal relationship between the counselor and the client. That's, we, believe me, I'm not a model for anything, but I have had some training. And there's something it's called Stages of Change Therapy, the something model, transactional model. It started out years ago, it was called motivational interviewing. And it was how to talk to a person to inspire change. And one of the principles is you roll with resistance. So if the person says, I don't think I have a problem, and I've had this experience, instead of saying, well, the data here says you do, you ask, well, why do you think you don't have a problem? And what do you think your experiences, what kind of conclusions do your experiences lead you to about your use of substances? Trying to get the person to verbalize what we believe is true. And because, you know, I hear this from people often, and I'm sure you do too, you can't make anybody change. If I don't want to change, I'm not going to get sober. And that's really true. And so what we try to do is help people see the need for change and try to discover what it is they're willing to do. Everything's a first step, you know. Everything's a first step. I have people who say they don't like to talk in groups, so they don't like to do any groups. And then they get into a group and they sit for a couple of weeks not saying anything, but then after a couple of weeks they've had some work that I've asked them to do, which means they have to speak in front of people. They find out that they do kind of like talking in groups, at least this kind of group, you know. Maybe they don't like talking in groups because they don't like being criticized, but that doesn't happen in AA either. It's just hard to make, people generally just resist change so much. When they don't want to go to any kind of AA, and that's just hard for some people, is say, okay, you don't want to go to AA, you don't want to go to the NA, you don't want to go to Smart Recovery, you know, all these are available within driving distance. You don't want to go to these groups, that's fine, but where are you going to get this support from other people in recovery that we know, so that we can make all the difference? You know, from where are you going to get that? That's fine, you don't want to go. What's your idea for getting that? Where can you go? Sometimes, yeah, I don't know, but people, they need to learn that they can solve this problem by making choices that are good for them. You know, if they don't have all the ideas, they don't have all the information, you know, maybe their first change is to listen to somebody else for once. You know, or try things out. It's not going to kill you. Nothing we do is going to harm you. Just try it out. It's just more resistance. And then you never know. People who say they want to quit, they don't really want to quit. So we give them room to say that too. You know? There are people who will say, I'm going to quit well, as long as I'm on probation. Fine. Let's do that then. Because no matter what we want, if being sober helps a person achieve their goal and get a better life, they can make the connection and they can decide to use it. And if they have the experience I have, this is the next time you use it, it's completely different, but it's just as bad. You decide not to ever do that again. You know, and the way you decide not to do that ever again is to make the changes you didn't want to make. You know, the statistic is statewide 40% success rate. I mean, people completing treatment 40%. It's almost a meaningless statistic because we don't know how often they've been to treatment. We don't know anything about these people. Nobody collects statistics. Ask the person who's been sober 5 years. What worked for you? How many times did you go to treatment? What was the last treatment like? If there was a difference.
Any other questions?
Thanks for what you do, Greg.
Thank you.
Thanks for getting me through this. I go through this period where hear I have to do it, and I think, oh, good, this always go well. And then I sit down and start making up an outline, and I think, oh, shoot. I used alcohol for anxiety, social anxiety. That was it, really, from the time I was a kid. And for a while, it worked. It just did. You know, I wasn't dependent yet, and I thought it worked because I escaped my anxiety. I've learned now to deal with my anxiety in different ways. You know, and one of the ways is to just be prepared. You know, things may not go the way I want them to, but at least I've got an outline. This is how I like it. And then if it goes off the rails, not to do that. At least it gets me over that. But I guess I'll do it on that. Thanks a lot.
Thank you.
Thank you, Greg. Thank you for bringing yourself to your presentation today. I think that was really impactful for everyone. And thank you for bringing these services to the community so that Cook County residents can receive treatment in their home environment, and your commitment to continuing education, that you're bringing these new evidence-based programs to the community. So thank you.
Thank you. And I remembered why I brought up the audit.
I know it would come back.
It was because I was kind of daydreaming about what it was like to work somewhere else where you get all these, housing isn't a problem, you got things to go through. And, you know, these audits are very stiff. They say, you know, just do these the same for everybody, nothing personal. And he looked at me, he said, he didn't say you got to be crazy. He said, you know, you got a really nice program up here, a nice situation. A lot of people who like it to be here, and just sort of reinforce how I feel about being here. I just feel I'm so grateful for everything that happened, everything, and the changes that I've experienced. And maybe that's the thing, because my boundaries are fuzzy, you know, kind of, but people in treatment know how bad I was and how happy I am now. Maybe that helps a little bit, you know. If you can make very good thing.
Bobby's got something.
Yeah, thanks for what you do in the community. And I actually graduated from Greg's program 9.5 years ago. In March, I'll have 10 years of sobriety, so it does work if you know, it took me 4 times to go to treatment before I finally quit. You know, I'm going on 10 years of sobriety now, but, you know, I went to treatment, 10 days of treatment in Duluth, and my counselor told me, she said, with your attitude, you're never going to stay sober. She just told me that straight out, so I left there and I came to Greg's program, and I've been sober ever since, so thanks what you do.
Yeah, this is a clap for somebody being
Yeah,
sober.
no kidding.
Because it is, yeah. Well, thanks for outing yourself.
He does it. He's a good graduate. He has no problem telling people.
All right, thank you.
Thank you, Greg.
A couple of your mints. They're not mine. You can have them.
All right, Allison.
So a couple things to share just briefly in the interest of time. We did receive notification that our child support program, which is another contract program that we work with Carleton County Public Health and Human Services to administer that program, that we received notification from the state of a need for a performance improvement plan. This was within the performance area of open child support cases with paternity established. Our performance rate was 89.71. The threshold is 90%.
Is this again based on numbers and we don't have enough numbers?
Exactly. And
Lovely.
the supervisor for that program, Dan, was savvy enough to really dig in to the caseload history to see that the Cook County caseload experienced a significant drop-off in the performance year, so it would have been statistically impossible for us to achieve that threshold. So he submitted what's called extenuating circumstances to the state to justify that there was nothing within the agency's control that caused that failure to meet the performance threshold. So hopeful that that DHS will look at the work that he's completed to justify that performance, and that we, or Carlton County on our behalf, will not have to submit and maintain a performance improvement plan.
Nice.
A brief update on the budget. I've shared this with the budget committee, but wanted to just say briefly here as well that the case aid position that was initially submitted in our 2019 proposed budget has been removed. Part of that was related to supporting the work that Greg does, and some of the additional services that were created with the substance use disorder reform. At this point, there are just a lot of unknowns in terms of implementation, reimbursement rates, and aren't feeling confident that we could justify that position in 2019. We're going to continue to keep it on the table and evaluate it for 2020 if we see opportunity to bring on additional staff person to administer those programs. The only other staffing change for 2019 is the additional hours within income maintenance for the full-time eligibility specialist. You'll see on our items for board action below, Jeff recommended that we bring that to this board today to approve that change. We did review with the budget committee last week as well. Again, these were hours that were in the 2018 budget, but that change in hours was not implemented within the budget year to date. Again, that's dependent on the transition to full-time veteran service officer, and that we would be backfilling Pat Strand's 20 hours per week in Public Health and Human Services with a full-time eligibility specialist. The last update I have to share with you is that we did receive written notice on Friday of last week that HDC is closing the Grand Marais office and terminating their contract with Public Health and Human Services. Our agency is working with providers in the community to determine how to meet needs during the transition. This is obviously a huge loss for the community. After Greg's presentation, we know that within behavioral health as a whole, which includes substance use disorders and mental health, that needs are only increasing. And then HDC has had a partnership with PHHS for many, many years in providing these services, supporting our staff directly, and just as a part of that continuum of care for the community. We are grateful that they are willing to help during the transition by providing some ITV support, and that other providers in the community have increased over the last few years their capacity within behavioral health, including the Sawtooth Mountain Clinic, and that there are some private providers as well in the community. So that is a strength for us in that respect, that that we know that we won't be able to completely absorb the caseload, but that we have some support. HDC has also assured us that this won't impact the employment services grant. That is a separate contracting grant through the Department of Human Services to support individuals in the community with disabilities, that they'll continue to staff that program, and that it will not impact the mobile crisis services as well. Unfortunately, the reason for why HDC is having to close their offices is workforce shortage, that they were unable to find staff to fill the positions and to retain staff in the positions. And I brought to share, I just thought this was a really helpful visualization of some of the challenges faced by rural communities in meeting workforce needs within mental health specifically. Cook County is not unique. This is happening in many areas of the state where loss of workforce with people leaving, boomers retiring, or people just burning out of positions, that this is really being felt throughout rural areas of the state. And truly, when there are workforce shortages in other areas, this has a ripple effect on other organizations, on public health and human services, on primary care, schools, emergency departments. And that these community-based services really, again, to speak to Greg's presentation, that when services are available in the community, we're keeping people in their homes, with their family units, with their jobs, and preventing more costly long-term interventions, out-of-home placements, and hospitalization. So at that, I'll just remind everyone again that crisis services are still available, and that you can find that information on our website, in our lobby. It's 844-772-4724, and that's the regional number for mental health crisis services.
Questions for Allison? Go ahead.
Allison, what about the psychiatric availability of Dr. Bauer through ITV? Is that going to continue, or is that ending as well?
I believe that would be an agreement between the clinic and HDC directly, that hasn't passed through our agency.
Okay, so we don't know, or we assume it's going to continue?
We don't know at this point.
Mm-hmm.
Any other questions?
Just to clarify.
Yes.
So our options are to contract with the clinic, and that's, or individuals in the community, or a combination of both? I didn't quite understand that.
We're exploring all options at this point during the transition, but certainly those would be included, that we do have some providers in the community, including therapists at the Sawtooth Mountain Clinic. Ascend Services is currently providing some of the skills work that HDC had provided in the community, some of the practitioner level skills work,
So
and that there are private therapists as well.
So I'm just curious to further that a little bit. So do you put out a statement of need and have certain criteria to develop a contract?
At this point, I don't think we have intentions of releasing an RFP or anything like that. We're just working to just help people, existing clients, through the transition. And
okay, so it's not a formal relationship to the county.
We have had a formal relationship with HDC in terms of some of the dollars that were passed through the Department of Human Services. So yes, we will be looking for 2019, and I've been working with Molly in regards to our contract and options for 2019. So I will share more information as I have it, and certainly bring it to this board for approval.
I was more curious than anything else,
Yeah.
not checking, but how that goes. Thank you.
Jerry, how much do you like retirement?
No pressure at all.
Yeah, really. It's a tough thing to hear, obviously, having worked at HDC. And I was going to talk a little bit about our advisory committee meeting too, where we spent a lot of time chewing on this, because it just is met with great disappointment and great frustration, because we have to find ways to provide these services. And I think that this handout says a lot. An unsustainable model. I think we're facing a sea change in how these services can be funded and how they can be made available. And it's aside from feeling disappointed in HDC, it has to go to a larger picture where you have to question, what's going on with funding, what's going on with insurance reimbursement, what's going on with, health insurance, the Affordable Care Act, a loss of support for that avenue as a way to have services funded. It's all kind of coming home to roost in a sense that we're now facing that we can't do business in the way we've done, and we are really in a big transition now to try to figure out what's next, what other constructive ways we can respond to this within the community, within PHHS too, as far as are there additional services that PHHS can take on or should take on, or should it be all farmed out to private providers? What do you do if there's no psychiatric connection to the community? I mean, that's a major service loss. And what do you do for people who have been in treatment who are cut off suddenly? How do they get any continuity, or how do they get any support when they're in the midst of therapy, let's say, or taking a med in the midst of treatment? And so it's a critical need as well as a long-term struggle to try to find out what replaces what we've had here.
Thank you. All right, Allison. Board action.
I would just like to comment on the Veteran Service Officer at the last budget meeting. Are we moving to that?
Yep.
Okay. She did come before the board, and we've been, asking her to give us an update on what she does, and she also did it a year ago, so that gave us the background that she needed to be supported on this, just to let you know that she was present at our meeting.
Well, besides that, it was approved in the budget by us.
I'm just telling this for the public.
Yeah.
So that this is already in the 18-19 budget.
So again, what we're requesting today, specific to PHHS, is approval to post for the 40-hour per week eligibility specialist effective immediately, knowing that in order for any new person coming in to learn the long-term care services, that it's 6 to 12 months before they can even begin learning that program. There are prerequisites in terms of learning just the basic medical assistance. I shouldn't say basic because it's very complex, but learning, having access to the systems that are required to determine eligibility. Our standard in training new financial workers is to have them learn the SNAP program first. That's the food assistance, or formerly food stamps program. In that's really that gateway program to learning the income maintenance eligibility programs, and just projecting out for the training that it is going to be some time before any new person will be learning the long-term care programs, but that we've had conversation with Pat and with the income maintenance supervisor, Allison Plummer, about that transition. But again, hopeful that we can begin recruiting for that position immediately and have some degree of overlap.
So Pat's new position would start January 1. Are we going to have a gap, or we're just, I know we've got enough specialists, but it takes 6 months to train, plus the hiring process.
In terms of the long-term care programs, we have built in some backup in having Agni Smith cross-trained in those programs. So more than likely, any transition will be in with Agni learning any additional work that she needs to be fully competent in the long-term care programs. Okay. And that in conversation with Jeff, it sounds like there would be a possibility for some cross-training supervision or training after the January 1st transition.
Okay. Any questions for Allison on item A, Veteran Service Officer?
I'd like to make a statement, I guess, because I made it to the Budget Committee, thinking about this for some time, and, I really feel as a county we need to send a message to our veterans that we're there to support them. And I think some discussion has been taking place in the community and paper and so forth, we don't need this, but if we err at all, we should err on having more availability than having less. If we have 3 or 4 that don't get served, or 5 or 6, then I think we've done something that's not good. And so I would really want to say to our veterans that we really appreciate, what they've done, and we want to recognize that. And so it's just not a matter of, I don't need it, or I don't want it, or someone doesn't need it. This is, I think, a bigger issue of providing a service and sending a message that everyone can access. And I think we should evaluate it, as well. And then that will give us, I think, the data that we have is, should we be serving more officers, or veterans, than we were in the past. But I think the previous system was convoluted a little bit, just trying to do two jobs. So I think it's a good move.
I know in 6 years, the only complaint I've gotten about Pat Strand's work is that there's not enough of her.
Yeah. So I would like to make the motion that we approve the veterans officer from 20 hours a week to 35 hours a week, effective January 1, 2019.
Support.
We have a motion and a second. Any further discussion?
Does this have an effect on this year's levy, coming levy?
It was included in the 2018 budget. It's represented in the numbers we've been working with in 2019, so no, it does not have an additional impact.
Okay, all those in favor?
Aye.
Opposed? All right. Item B, any questions for Allison on the eligibility specialist posting? Can I get a motion?
I will move to post 48-hour-a-week eligibility specialist effective immediately for 2018 and 2019 budget.
Second.
Any questions? All in favor?
Aye.
Any opposed? Motion passes. I was going to say December, but we're going to have a new commissioner. Can I get a new, we all need a new chart. As you can see, I try to update it at every meeting, and it's getting messy. All right, committee reports. Arrowhead Economic Opportunity, Myron.
Oh, okay, well, we had our annual meeting in October, and it was very long. And what we did was approve all of the federal and state requirements for all the funding programs, and we spent a lot of time on Head Start, which we don't have in Cook County. We don't qualify for it, but AEOA runs Head Start for most of the Northeast region, and the reports were pretty good with that. So that was basically it. A lot of approvals and dotting the i's to do contracts.
Thank you. Arrowhead Health Alliance, Jan.
Thank you, Madam Chair. We focused on a number of things, but one could be perceived as good news, could be perceived as bad news, but the Birch Tree Center occupancy went from 50% that it's been in since it opened pretty much to 60% this month. However, we view it as good news because we launched a marketing program, which you're all aware of about a year or so ago, the Let's Talk campaign, and had a concert with Charlie Parr, et cetera. So we really feel like that extra effort that's out there is letting people see what service is offered, and so it's being used more. So that's a good thing. And I think the marketing campaign speaks to it because Wellstone Center on the Range is still at their 50% level. So this increases happened only at the Birch Tree Center. So I think regionally the marketing would say that that's probably but you never really know if the marketing is working. But we're looking at it as a good thing. Sort of a development that will be occurring, Rick Schaefer, who is the executive director, has asked the board to look at, evidently this Clarity project has involved him in some networking. So he is talking with ARDC, and I don't know if anybody at ARDC is talking about this, but there are only 2 employees of Arrowhead Health Alliance, Rick Schaefer and Savannah, who's the tech person who gets all the videos throughout the region up and running and maintains that system, et cetera, which has been a remarkable amount of work that's happened in the last couple of years. They're looking to become employees, I'm not really sure of the exact way, but employees of ARDC. So under that organizational structure, they would be eligible for some benefits, which seems like a good thing to see happening, since there are only 2 people that they would feel sort of isolated out there, and for them to be able to be eligible to receive para and a few of the benefits seems like a really good strategy for recruitment, not recruitment, but maintaining these very good employees at AHA. And it also makes their work more interesting. And it sounded like from Andy Hubley thought it would make the work of ARDC more interesting, that there would be this mental health screening that would go through all the decisions at the ARDC. So it seems like it would be mutually beneficial merge. So it's really interesting to think about mental health from an ARDC perspective too. I mean, it's just kind of fascinating. Some synergism could be created there. We talked a lot about the Clarity Project. We didn't really talk about it. Alice and I attended upstairs, and I would say that the folks attending the meeting were pretty quiet, so it's really hard to hear what they were talking about, particularly when it came to their conversation about the Clarity Project, which is evolving, but is, I could sum it up in my perception of it. Dave Lee said mental health is messy, and that's what I heard from all the people talking about the Clarity Project. It's going to be really messy. The whole idea of bringing the medical industry under a roof with the mental health industry, it's a really interesting concept, but it's going to be messy. That's what I heard. Lots of angst in how they work together, and because they have different for-profit government agencies. It's just really, it's messy. But that's good things. Good things are happening. Life is evolving, and I'm excited that the Birch Tree Center is being more utilized. I think it started January of 2015. One of my first meetings. It was just getting going, and that first month, attending the grand opening of the Birch Tree Center and watching it evolve, it feels really exciting to see it kind of going to kindergarten and starting to have a bigger effect. That's it.
All right. Bobby, Arrowhead Regional Corrections?
Took us till like 10:15 to get a quorum because Wade's car broke down, so. We just went through all the numbers, and then we had a presentation on the Ignition Interlock program for the drinking and driving. They have, I don't know if you know Tony or not. She got hired as an analysis for ARC, but it was like a real good success so far for the numbers that she's done, like 4% recidivism. You know, so that was a pretty interesting. Other than that, it was
stuff they add in cars these days, that should just be automatic.
Yeah, but it was a very short meeting because there was very few people there.
Did the chair make it?
Yes.
Good. That's the most important. All right, Ginny, Arrowhead Regional Development.
Yes, thank you. And we did discuss the transition of those 2 folks.
Yeah.
We thought that will be great for the future to coordinate all of that together under, they won't have office space, they'll
Right, they'll
continue
maintain
where
their
they
office
are right
space.
now. Yeah, so that was good. The other thing that ARDC is looking at, Andy Hubley gave us an overview of all the different areas that they've been involved in, from revolving loan fund to transportation to parks and recreation and all that. They're now looking into childcare, and that would be helping counties with a child care facility, not private, but a more public one. So they're just in the beginnings transitioning to looking into that. that's the two updates there.
Thanks. Community Health Board has been a little busy recently. Lots of trips to Two Harbors. So I had a personnel meeting to go over the budget with staffing, and we had people that couldn't make it and people who went to the wrong building and then left. And so some interesting conversations that will have to be finalized via email with the staffing, and Louise will be making a transition this year. So, yep, more to come. But it'll be interesting. There's always changing. Things are always moving. And then we did strategic planning, and that was Frankie Jarko, many of you know her, and Joni and Allison and I went out in a lovely wintry weather like this down to the Two Harbors High School and did some strategic planning, which was interesting. We had a really good turnout for that. I think all the seats were full, and that went pretty good. For me, this is my first year on community health, and so like you were talking, eligibility specialist needs 6 months of training. I think I need 4 years of training before I even know what's... Joni looked at me at one point and said, "You're awfully quiet," and I said, "I'm just absorbing it all." It was a lot.
It's complicated.
It is. It's complicated and huge and affects a lot of people, so. Allison, anything you want to say about that strategic planning?
Just that I am still in learning mode very much with the Community Health Board as well, but I felt like this strategic planning exercise was really helpful for me in understanding, the scope of the work, some of their goals for the future, kind of visions for change. What else could this look like? And it was just great being in a room with all of those people. Typically we attend via video, and that just has a very different dynamic. So being at the table with some of the commissioners from St. Louis and Lake County and the public health leaders from those counties as well was really great. And just appreciated time in the car with Heidi and Joni and Frankie. That was really nice as well.
Solving all the world's problems as we were trying not to look at the weather as we were driving. All right, Public Health and Human Service Advisory, Carla and Jerry.
Jerry has the meat of the program to report on. I just wanted to say one thing, that on January 19th, there will be a workshop at Higher Ed on self-care for daycare providers and parents, and I think this is wonderful. So it's in the works, the planning. And Frankie will continue on the healthcare board.
Just to add on to the piece about daycare providers, I was surprised to learn that in the report from the Early Childhood Coalition that there are only, I hope I have this right, there are only 2 licensed family daycare providers in the county over and above Cooperation Station and the YMCA. The response from PHHS is a very good one, that holding a meet and greet to try to encourage potential providers and send out invitation letters and do what can be done to enlist more people who might take up that task. But that just seemed like a startling thing to me when we've talked so much about daycare availability, that there are only 2 providers. I really said my piece about the HDC. I don't think I have anything more on that.
Okay, thank you. Healthcare Planning Committee, Ginny.
Thank you. Well, we had interesting report from Rita in terms of hiring right now a nurse or 2. And ironically, in October, I received a pamphlet and a letter from the president of the Nursing Association in Minnesota giving the red flag that the nursing shortage will be getting worse. And so I thought it was interesting that I received that information, but that was great because I'm on health committees here and there. Not encouraging, but we keep hopeful that with everything going here, housing and great place to live and all that type of thing, that she will be able to fulfill that. And at least here with the county, we've been able to hire someone for public health nurse. Jody gave an update on some of the work that they're doing with violence prevention in the schools. And Allison was there to give a report from the county. And that's it.
Great, thank you. North Shore Collaborative, Jan.
Didn't meet, it'll meet next month.
Okay, emergency preparedness, Ginny.
I haven't been to anything lately, so.
No, we haven't met, but I have it on the calendar for next week, but haven't heard yet.
Yeah, I think it was because we did the update on our hazard mitigation, and you guys had chest deep in budget
Yeah.
stuff.
How did that go?
Could I just raise an issue that I was reading about in an article, and maybe you're already doing this, but for vulnerable, people with physical disabilities or frail elderly, are they on a list if there's an evacuation so that somehow they get out? And you think about the California wildfires.
Oh, man.
Right.
Wasn't always
You
just
have a list for Grand Portage, right? Well, not you, but your public health.
I'm sure Mike has something.
Yeah, and then that wouldn't be through our office.
I believe that was an action item that came out of our sheltering that took place earlier this year, that public health was going to work with law enforcement. And I don't know exactly what the status of that is, but I can bring that to a future meeting.
Hospital and clinic would know who their patients are, but that's not something they can share necessarily.
I think we were looking at it in terms of the lens of adults that our agency is working with in the community.
Yep.
I do know that in the most recent sheltering that we did work with the hospital to determine a location for people who needed oxygen, and that was a part of that response.
Okay, good question, Carla. And the hazard mitigation went well. There's 53 items on there for action.
Okay.
And you'll get an updated report on that.
Okay, thank you.
Would anyone like to adjourn?
So move.
All right.
Snow.
It's supposed to be less than half an inch.
Yeah, well, keeps